Let me introduce you, if I may, Dr. Villanueva-Meyer. I meant to do that earlier, and I apologize.
No problem.
He,
Thank you.
he, he, he is an associate professor in the Neuroradiology section in the Department of Radiology and Biomedical Imaging at the University of California, San Francisco. He received his medical degree from Baylor College of Medicine in Houston, Texas, and he completed his one-year internship at Virginia Tech, Carillon School of Medicine in Roanoke. He completed his four-year diagnostic radiology residency at UCSF, followed by a neuroradiology fellowship also at UCSF. He also completed an NIH, so National Institute of Health, T32 postdoctoral fellowship in the UCSF Department of Radiology and Biomedical Imaging. His interests focus on advanced MR imaging and imaging-based tools to better delineate and characterize brain tumors. Thank you. His research also involves molecular imaging, where he works with collaborators within and outside of his department to develop and implement the use of PET radio tracers in both brain tumors and spinal infection. He has experience in CT, MRI, and plain film radiography of the brain, head and neck, spine, and peripheral nervous system in both the inpatient and outpatient settings. And there's lots more, but we'd love to hear from you directly. Thank you.
Thank you so much for that introduction. I really appreciate it, and thank you for the invitation to join this group. As a neuroradiologist, we are not directly patient-facing. I do a fair amount of procedures in my practice. However, that's mostly geared toward pain interventions. So on the oncology side, always appreciate any opportunity I can to meet and interact directly with patients. So again, thank you for that. And I think that's a great segue into the critical role of imaging in neuro-oncology. Every visit is essentially punctuated by imaging, organ, in that we don't have easy way to understand the status of disease within it when it comes to brain cancer. We can't just, sample the tissue. We don't have great blood-based or even cerebrospinal fluid-based biomarkers. There's a lot of work in that space right now, and the hope is that in the near future that will be the case. But for current state, imaging, neuroimaging is really the primary way by which diagnosis and treatment response is done. Unfortunately, our current imaging techniques, the standard of care we have, aren't as sensitive or specific as we would like. The bread and butter types of imaging that we perform, T2 FLAIR and T1 post-contrast MRI, this is anatomic MRI, can represent tumor or not tumor, as highlighted in these example images, where we have tumor, edema, and gliosis or scarring, all showing up as bright signal on this T2 FLAIR. And then post-contrast enhancement, which you can see on this bottom row here, can indicate either progressive tumor or treatment effect. And so every day when we're out in clinical practice, we're in some cases, it may be pretty clear cut, but in many cases, we're kind of left scratching our heads. And so we have a number of additional tools that are at our disposal that we've developed to try and help us sort this out. And I'll call them out here, where most imaging centers will include what we historically have called and still call advanced imaging. So diffusion-weighted imaging and perfusion-weighted imaging that speak to cellularity of tissues as well as blood supply within those tissues. And in some cases, we may bring patients back for MR spectroscopy, which allows us to understand what's going on in terms of the metabolic activity of tissue. We use this for troubleshooting technique. We mentioned earlier positron emission tomography or PET imaging. This is another great troubleshooting tool that we're looking to integrate more and more into routine clinical practice, and it'll be the focus of what we're talking about here. And then there's some other bleeding edge technologies that are really sort of coming out of the research realm and into the clinical realm. One of those is hyperpolarized carbon imaging that also allows metabolic imaging, but in a little bit more of a dynamic fashion. More often than not, as I mentioned, we're unfortunately left just getting repeat imaging for our patients. So we see something that's indeterminate. We try to use these tools to the extent that we can But more often than not, we end up having to have the patients come back. I'll call out that sometimes, unfortunately, when that happens, the cat is already out of the bag. So here in this bottom right example, we saw a little area of bright signal on this T2 flare where I'm hovering my mouse. It's very small, very subtle. We didn't really know what to do with it. We said, come back. And unfortunately, by the time the patient came back, this lesion had already grown and there was an additional lesion as well. And so that's the emphasis of, or the aim of many of these metabolic imaging tools, is to try to understand what's going on underneath the surface and try and catch disease before it limits, you end up with limited treatment options, right? So that's the end goal here. And I'll also call out the fact that there really is no singular silver bullet when it comes to imaging. Each of these tools, or each of these different techniques, represents an opportunity to reduce our uncertainty as clinicians. And so, we stack all of these things together. There's not one single one of these tools where it's like, okay, based on this technique, it's 100% this is what we're dealing with. It's really, we're playing a game of odds, and each of these things help us to varying degrees, and unfortunately, varying degrees in every case and every patient. They're all very, very different. So because of that lack of sensitivity and specificity, as I've kind of already been alluding to, we're left with a host of unmet clinical needs. We have definitely a need to better monitor treatment response to conventional therapies as well as to trial therapies. And in the trial setting, we really want to know what's going on as soon as possible so we can make distinctions or any changes to these novel trials that Dr. Groot mentioned earlier. We also have a need to predict malignant transformation, again, helping us understand what's going on beneath the surface, beneath the anatomic imaging. If we had a way to understand, okay, this tumor is going to be more aggressive, that would be incredibly helpful. Identification of additional sites of disease, and then also helping us understand the relevance of this non-specific T2 hyperintensity that I mentioned earlier. And lastly, diagnosis and prognosis. In many of our brain tumor cases, the first line of therapy is removing the tumor. So for that reason, I kind of put this last, is that these patients will often, many patients will often have to have surgery first for diagnosis anyway. So while it's great that we can try to give the best guess right up front, if we, if we can't clearly define exactly what kind of molecular markers the patient has, that'll be fine because the patient will undergo surgery and we'll have that answer then. So Dr. Groot showed you earlier an example of the classic problem that we face in neuro-oncology, which is that of treatment effect versus progressive disease related to the lack of specificity of our standard of care imaging. I'll show you another example here. These are two patients who both underwent gross total resection of high-grade glioma, and what that's defined as is resection of the enhancing or contrast-enhancing part of the tumor. In these two examples, we see no residual contrast enhancement. This top one, you can argue that there's some bright signal around this. I'll tell you that all represents blood products, and it's not true contrast enhancement. These patients both underwent chemoradiotherapy, so the standard of care treatment with temozolomide and radiation therapy. Following completion of that chemoradiotherapy, they had growth of contrast enhancement around the surgical cavities, as you can see on both of these images. The patient on the top continued to have growth of that contrast enhancement. Now it looks bulky and nodular, whereas the patient on the bottom, that enhancement started to fade away. So the top patient represents progressive disease, whereas this bottom case represents pseudo-progression or treatment-related changes. So what we would like to know as treating clinicians is, based on this middle exam, which one of these represents growing tumor versus which one represents treatment effect, so that we can make appropriate changes in our management and not have to wait that 4 to 8 to even 12 weeks in some of these cases to make a treatment change. So to help address that ambiguity, I mentioned earlier positron emission tomography, or PET. This is a nuclear medicine study that relies on injecting a radiotracer. So it's a small radioactive agent that's injected intravenously and taken up by tissues, and helps us understand what's going on from a metabolic perspective. The classic PET imaging agent that you maybe have heard about is called FDG, or fluorodeoxyglucose. Essentially, the premise behind the use of this agent is that cancer cells are metabolically active or hungry, and so they take up glucose to continue to grow. And they do that at a greater rate than normal tissues around the cancer. And so the challenge that we have with using FDG, which is the most commonly used, or fluorodeoxyglucose, the most commonly used radiotracer in oncology, the challenge we have in the brain is that the brain normally takes up glucose. And so you have a lot of background uptake of this radiotracer, and it can obscure subtle findings within the lesion. And so as a result, using that same premise that these cells are more metabolically active, so they're requiring these building blocks, amino acid PET agents have been introduced, now routine clinical use. So these have come out of the research realm and are really in clinical use in Europe. And we're working hard here in the United States to get FDA clearance for these agents. And that's part of the work that we're doing with Helix in collaboration. So these amino acid PET agents, there's a number of them. I highlight three of the most common ones here: FET, or fluoroethyltyrosine, FDOPA, which is also used for Parkinsonism, and MET, or methionine. These all represent amino acids or building blocks of proteins. They're going to be taken up by cells that are more rapidly dividing, that are growing, and therefore, more likely to be synonymous with cancer versus something that's inflammation, where you don't expect to see that high level of uptake. There's a couple of other agents, such as FACBC, that I call out here. There are some other agents as well that have been studied in neuro-oncology, but those they're targeting different aspects of metabolism. So fluoroethyltyrosine has the benefit of having no further metabolism. So they're just basically taken up into cells and they're not broken down any further. So that's great for the type of imaging we're trying to do. They circulate in the body for around 2 hours, which is also good from the clinical perspective in terms of imaging. Some of these that are carbon-based radiotracers, as you can see here on the far right of the screen, have a very short half-life of about 20 minutes. So you really need to be able to image them pretty quickly. This again highlights the minimal uptake in the normal brain that I was describing, and underscores how much easier it is to see neoplastic or tumor tissue relative to the background activity in the brain. So that's why we like this agent. And so with that, I'm going to sort of tag team this now with Dr. DeGroot. We're going to talk about a couple of cases where we used this radiotracer at UCSF as part of a trial to help us with some of the ambiguity that we saw on MRI. And so I'm going to hand it over to Tim to run us through this case, and I'll talk through the imaging findings.
Yeah, so the first case is really a question of, are we dealing with recurrent glioblastoma? 62-year-old male with GBM, MGMT methylation, and then went on one of the immunotherapy trials that I mentioned before, where the patient was treated either with nivolumab or placebo for newly diagnosed glioblastoma. So that included radiation, concurrent and adjuvant Timidar with or without this immunotherapy, and while on treatment developed some imaging changes.
All right. And so those imaging changes that we're describing here are shown on screen right. This is an MRI. This is a post-contrast image, and you can see that there's some contrast enhancement along the left lateral ventricle. Remember, in imaging, the right and left are flipped. So we see some enhancement around the left lateral ventricle. There's also some swelling or some edema around it. Because of those changes, we got a short interval follow-up. So we had the patient come back at 4 weeks' time. And at 4 weeks' time, that enhancement continued to grow. You can see this lesion is bigger. But interestingly, there's a lot of necrosis associated with this lesion. This is a lesion that if I were reading, I would say, okay, it's growing, yes, but there's a lot of necrosis. So maybe I would favor it to be, while indeterminate, I would maybe favor it to be more treatment-related changes rather than progressive tumor. Patient went on to get fluoroethyltyrosine PET MRI, and here we can see that there is some uptake within that lesion, but you can see relative to the rest of the normal brain, it's not very, very high. And I don't have the color scale here, but I can tell you that this is not something that would be classified as visually positive. We can also get some quantitative measures from this. So we can look at what's known as a tumor to background ratio, and tumor to background ratio above 2.3 is considered positive. Here, this tumor to background ratio is 1.5. So this is what we would call a negative study. This patient underwent surgery, biopsy, and I'll just call out that this was found to be predominantly treatment-related changes, and viable tumor was found in less than 5% of the pathology. So
yeah, so this, the patient really went to surgery because they were on a clinical trial, and we really needed to know, was this actually, tumor progression, at which point we would have to take the patient off. But the FET-PET favored treatment effect, and that was confirmed at the time of biopsy. So the patient was able to continue on treatment following surgery.
And this is our second case here.
Yeah. So the second case is also a question: is this recurrent glioblastoma or not? This is a 46-year-old woman with an IDH mutant astrocytoma, WHO grade 4, MGMT methylated, underwent a subtotal resection, radiation with concurrent adjuvant Temodar, and then 7 years later, without any progression in between, had some imaging changes that were concerning for potentially radiation effect.
All right. So again, on screen right, we have the index MRI where we see a resection cavity in the right temporal region. And just along the back margin or the posterior margin of that, we see some areas of contrast enhancement. You see these little bright dots here. It looks kind of fluffy. And then this person undergoes a standard 8-week or 2-month imaging follow-up. At that time, it's pretty obvious this lesion has grown, but there's some mass effect associated with it, meaning it's kind of bulky. It's extending kind of into the cavity or pooching into the cavity there, even though there's some necrosis. So this is something that I would read as indeterminate, but favor growing tumor, favor progressive disease. This patient also underwent fluorethyltyrosine PET. And here, in contradistinction to the other case we saw, we see that there's a lot of red in this lesion, right? So this is something that is visually positive, so qualitatively positive. And then if you remember, I mentioned the tumor to background ratio. Numbers above 2.3 are considered positive. This is 3.4. So this is unequivocally positive tumor based on the fluorethyltyrosine PET. This person underwent surgical resection, and as noted here in bold on the pathology report, approximately 70% of the tissue is viable high-grade glial neoplasm.
Yeah. So despite the imaging changes that were concerning, but maybe indeterminate, the FET-PET really actually drove the decision to take the patient to surgery, and pathology confirmed, recurrent disease. And of course, that's critical for planning the next stage of treatment for the patient.
Perfect. Thank you. So some quick lessons learned from our early experience with amino acid PET at our institution. Number one, as I mentioned earlier, these tumors are incredibly complex. There's different molecular underpinnings to these tumors, and patients undergo a number of different therapies. There's not really a one-size-fits-all or silver bullet here. Metabolic imaging brings a wholly new dimension to our armamentarium to help patients. So when you see changes there, do go back and re-review the MRI. I think something that's critical is exactly what you're seeing here, where you see Dr. DeGroot and I speaking back and forth, this multidisciplinary approach where you have radiologists, pathologists, radiation oncologists, neuro-oncologists, and neurosurgeons, everybody working in concert to treat this disease and make sure the patients are being managed appropriately. All of those things are critically important. And so with that, I'm happy to take any questions. Really do appreciate, again, this opportunity.
Thank you so much, Dr. DeGroot and Dr. Villanueva-Meyer. Wow, really impressive. I feel like I want to cut radiologists some slack. You know what I mean? When you're looking at those images, right? Because it's true. You don't exactly know what you're looking at. I have a question for you. So the FET-PET, right? Just if it moves forward, right, and it keeps continuing, the data keeps showing response, et cetera, and eventually this is FDA approved, it's a game changer for these patients and these caregivers and family members because of the terrifying times, before an MRI for the patient and their family. It's terrifying. It's horrible. Yeah. And thinking about this application, obviously this application would determine if it's, tumor growth, real tumor growth, or, treatment effect, or basically I say fake tumor. I just can't imagine the change in the landscape related to surgeries that this would then offer up. Has there been talk about that aspect of this particular treatment approach, diagnostic and treatment approach?
Yeah, absolutely. So I really appreciate you calling out that the emotion attached to basically coming up to the MRI, and then after the MRI waiting for the report, waiting for the results. I totally heard, and that's something incredibly important for us to keep in mind as we're making these interpretations, and what that means for you all as patients and caregivers. So that all of the examples I showed of fluoroethyltyrosine PET or FET PET were really single time point, right? It's really just help us troubleshoot at this one time point. The next chapters that are to be written with this agent are, how do we use this to better define treatment up front? Just like you said, like, surgery. Okay, we have this huge swath of MRI abnormality, but the areas that are metabolically active are here. So let's preferentially go after this. And then the other next chapter that I'm really excited about is really using this at multiple time points in the same way that we use MRI, right? So how is somebody responding, even though their MRI might not be changing, or maybe changing in a potentially, kind of questionable way? If we can show that there's metabolic change within the tumor, slowing the rate of growth or anything to that effect, that is also, one. So just speaking of, just to add on to your enthusiasm and excitement, that's what we're excited about in terms of where the field is going.
Fantastic. You answered some of the questions that came in, which were, what will the future for, radiotherapy in brain cancer be? So you just answered some of that there. Someone wrote in, they're a family member of a GBM patient, and they wrote in, would like to know more about Telix, how to get it, and if insurance covers it.
Right. Yeah, I mean, Telix has really been in the field of radiopharmaceuticals for quite some time across multiple indications, not just for brain tumors. As you mentioned, they're more recently new to the brain tumor space. They are working very hard to get FDA approval for the FET-PET. It has been approved in Europe for the last 20 years, and so they've been able to do it in Europe. I think if it gets approved, then there will be efforts to make sure that this is paid for by CMS and then by third-party payers. I think there's some questions about, how long that might take, and then, to what degree could we do some of the things that Dr. Villanueva-Meyer mentioned, like do this serially? Would they pay for it just once, or would they allow us to do it, every 8 weeks? So lots of uncertainty around that.
Right. And yes, the future will tell. As patient advocates and as a patient advocacy organization, Telix does know this, but we're in a position to help when it comes to the approval process. And of course, with Medicare and that work, we've done quite a bit of that in the past. And it's extremely important to bring this forward for approval. And yes, it takes a while, but it's advocacy. And also, it's not just advocacy organizations that can help make a difference. It's everybody that's tuning in today and more, because what we can do oftentimes from an advocacy perspective, we create the movement, we create the opportunity to hear from patients, caregivers, their family members, healthcare providers, about how important it is to have something like this diagnostic imaging opportunity approved. So I foresee that happening in the future. So this is a pre-invite to join us in that movement in order to increase patient access, as well as, in my opinion, increase survivorship, really, when you know what you're looking at as far as tumor tissue. So I have a question, and I asked this as a friend. Villanueva-Meyer, there was a slide, and your slides aren't numbered, but there was a slide you were talking about, and you had an image up there. It was an initial image, I think, and then maybe, I don't know, it might have been 8 weeks later. But the first image, it showed what you couldn't, the white enhancing, and you said we didn't really know what to do with this. Do you remember?
Yeah.
Okay. So my curiosity is, what would have been a different approach? I'm just curious, and I'm asking this literally as a friend. I don't want to put you on the spot, but I think about if I'm a patient, right, and there's something there,
Yeah.
I
Yeah.
want something done immediately,
Yeah.
right? So I'm just curious, what
Yeah, so I think you're referring to the first case where there was something that was growing, and I said we didn't really know what to do with this. And I remember actually having the phone conversation with my neuro-oncologist colleague. This was a patient of Dr. Oberheim Bush's at UCSF. And, it was just the imaging was obviously growing and convincingly growing. And the patient was somewhat symptomatic from the edema, right? And so from the swelling. And so there was a question of, just as you said, the patient wanted something done. And so despite, my reassurance, and this was actually, I believe this was one of the first 5 patients we did with fluorethyl tyrosine. So there's a little bit of a learning curve that was associated with this. So there was like, well, it's telling us it's negative, but there was this pressure, like you said, from the patient. I want something done. We have to know what this is. I'm tired of dealing with this uncertainty. So let's biopsy it. And so they did. And that's when it came back that this was all necrosis. And so since then, that helped build our confidence in that imaging tool to now say, convincingly, let's call it, have that discussion with patients and say, look, this is telling us it's negative. We're convinced, we feel strongly this is negative. And so, we're going to stay the course, or we're going to manage you with steroids or anti-angiogenic therapy, what have you. But I think it's a good call out, because that same feeling was felt by the patient at that time. And that was early enough in our experience with this agent that I wouldn't say it's not that we had full trust in it, but there was a little bit of that uncertainty.
Yeah, and the point is too, like with FET, you literally could introduce it early and with confidence.
Yep.
Show the patient, and that that patient is just going to have a huge sigh of relief.
Yeah. And for that, we're thankful for our patients who enrolled in this clinical trial. That was the largest prospective clinical trial that's been done to date with this agent. And that patient's uncertainty gave us the certainty to now move this forward, right? So it's amazing how the field progresses.
Wow, that's great. I mean, I'm speaking for all of you, but I know everyone listening today is just really excited about this. Well, I have there's a couple of questions that came in, and also please remember, you guys, we've got a couple of minutes. Someone says, with the FET-PET imaging, do you believe there will be a nutritional metabolic, I think it's effect. Let me read that.
Yeah, I see that. That's an interesting question, and one that certainly should be explored. So we do ask for fasting, for example, with this beforehand, because we know that the degree of and in some cases, like even a low protein diet prior to this, because it helps facilitate how much uptake there is into the lesion. Now, that's not necessarily what this question is asking, but I share that just to say that there is some link there that needs to be studied further.
I also would like to see a nutritionist as part of the integrative team everywhere for multiple reasons. Can you see Dr. DeGroot? Did you see? I want to congratulate Dr. DeGroot on his move to UCSF. He helped me when I was first diagnosed with GBM back in February 2020 and overwhelmed where I should go for my care. Wanted him to know that I'm still here living with GBM over 5 years.
That's amazing. And thank you for the congratulations. I'm super happy where I am, although I miss a lot of my friends at MD Anderson, but I'm glad you're doing so well. That's really amazing.
That's very cool. I love it. I love it. This is a question that I wanted to open it up to whoever wants to answer it, doctors. It came from California, and they indicate they're a caregiver. Their question makes me wonder. We have a number of patients trying to decide on neurosurgery and having a challenging time deciding due to a tumor or cyst location that could cause harm or damage after effects. Any words of professional wisdom?
That's a tough one. I think, obviously you have to feel very comfortable with the surgeon and your care team. I think it's always a good idea to get a second opinion when you're dealing with, a major medical challenge. And so I think that would be just my only other suggestion would be to seek a second opinion.
Oh, yes. Yes. Well, and as a patient advocacy organization, we always suggest and help patients receive that second opinion for sure. Right. This is the last question, unless someone listening has a question they want to put into the chat box. And this is to whichever doctor would like to answer this. How PETs can be used for brain cancer and other monitoring options that don't use contrast?
That's a good question. So you don't need contrast to do additional contrast to do this. It is helpful. It is helpful to have the comparison side by side. And many institutions now have what we have, which is a hybrid PET MRI scanner. So the PET imaging happens at the same time as the MRI. Do you absolutely need contrast? The answer to that is no, but it is helpful. Do I see a world where maybe we move away from intravenous contrast and just use the PET potentially, but not. I don't have super clarity on that. So, yeah.
Yes, thank you. Thank you. A quick question came in actually from our patient navigator. Do you offer telehealth appointments for out-of-state patients?
Yes, we do.
Fantastic.
Yeah.
Fabulous.
Simple.
Thank you for doing that. It's a game changer.
Yeah, it's critical, I think, to get access, and particularly for patients who don't have necessarily access to specialized care where they live.
Yes, absolutely. So that is all the time we have for you, gentlemen. I want to thank both of you, not just for today and presenting, and everyone's going like this, yay, but truly for your commitment to this disease and this patient community and the research community. Someone just put up a nice heart. That was cute. Anyway, thank you so much.